Good evening, everyone, and greetings from Italy. My name is Gioele Simonte, and I'm a vascular surgeon working in Perugia, which is a small city in the central portion of the country. We have here a live-in-a-box case about a female patient, 69-year-old, with a right asymptomatic internal carotid artery neuroocclusion stenosis. You can appreciate here on the three-dimensional reconstruction and X-ray images the quite high carotid bifurcation and the calcified yet segmental plaque at the origin of the internal carotid artery. According to the preoperative plan and to our measurements, a 4 centimeter coverage is enough to treat the disease segment. So we begin the procedure performing local anesthesia right on the operative table, feeling the common femoral artery pulse and using a 2% mepivacaine solution. After that, after waiting a couple of minutes, direct punction of the common femoral artery is obtained, checking the entry site high under fluoroscopy, and using a standard Seldinger technique, a guide-wise advance into the needle, and a short 8 French introducer sheet is positioned at the access site. You see here the advancement of the 8 French introducer sheet in the right patient's groin. At this point, the arterial line is connected directly to the working channel, obtaining immediate arterial pressure measurements and continuous line washing. And you see here the arterial line curve monitor showing blood pressure of the patient. A diagnostic catheter is then advanced up into the arch, tip curvature depending on the anatomy identified on the preoperative CT scan, but in case of right common carotid artery engagement, it is generally an edenter catheter, as in this proper case. You see the tip of the catheter flipping into the nominate artery. Once the common carotid artery cannulation is confirmed with contrast injection, a J-tip or 35 guide wire is advanced up to the middle portion of the common carotid, the diagnostic catheter retracted, and an 8 French guiding catheter 6.7 French inner diameter is used as a long introducer sheet and advanced to a final stable position a few centimeters proximal to the carotid bifurcation. The arterial line is then switched and connected to the guiding catheter and the working projection identified, injecting contrast again. A distal filter is then prepared and advanced. To obtain some directionability, we prepare the tip aiming to gain a smooth crossing of the stenosis. The lesion is then crossed using the roadmap, and the filter is released in a healthy internal carotid artery distal segment. You see here, holding firm the position of the distal filter, we set free by pulling back the delivery system. The delivery system is then removed, and we are finally able to advance our micromesh device. We are really careful during this part of the procedure in checking for air embolism, and we stop several times during the stent advancement into the system to eliminate any gas trace from the line. See here our air bubbles are being eliminated from our line going through the T connector proximal to the valve. Once the stent, which in this case is an 8 millimeter, 40 millimeter in length, is advanced to the stenosis origin of the internal carotid artery without performing predilatation, in this case, as in about 95% of our cases, the device is released with a pull-back mechanism and the plaque is fully covered. The stent tip can be then retracted and a 5.5 millimeter or 6 millimeters, depending on the diameter of the internal carotid artery balloon, is advanced, while atropine is administered to prevent bradycardia and hypotension. Here you see the advancement of the balloon, and then quick post-dilatation of the stent is achieved. And you can see how after post-dilatation in this high-quality image, the stent really adapts to the patient's anatomy. At this point, we are ready to advance the distal filter retrieval system. The filter is partially recovered into its catheter, and this to avoid any squeezing of eventual material inside it. Quick removal of the distal filter, and then we can perform final angio checking, confirming complete resolution of the tight stenosis and patency of the intracranial major vessels. Guiding catheter can be then retracted, and the arterial access of the right groin can be used using a ProGlide in the standard fashion with the post-implant technique. Now, this was a pretty straightforward case, but it served to describe our technique for carotid engagement and stent delivery. With this practice, and thanks to the C-guard flexibility and adaptability, we can easily treat more challenging anatomies, like in this case with a really angulated origin of the internal carotid artery, where the final result is definitely satisfactory. Another case here where I would never use a closed cell stiff carotid stent, strict coil after the origin of the internal carotid artery with perfect results after stent deployment. Finally, another really tough anatomy in a patient with previous neck irradiation, a double 90-degree angulation. You can appreciate lesion crossing, again without predilatation, with a filter and with a C-guard, which is advanced, determining some degree of anatomy straightening, but again with a perfect result at the end. So in conclusion, using the proper technique associated with the advantages provided by the C-guard stent in terms of embolization prevention and adaptability to challenging anatomies may represent the best contemporary solution for our patients with carotid artery stenosis. Thanks for your attention.